project is here, and Gillian Kupakuwana, so welcome, coming from Colombia. And Gillian is going to be doing her project in Zimbabwe, and it's a nice follow-up.
Thank you. So I'm a second year medical student in Colombia, and I'm kind of taking the year to do research. It's kind of unconventional because I think it's done at the third year of medical. So I'm studying deterministic people in HIV-affected children in Zimbabwe. Oh, can you hear me at the back?
Yeah.
That's great. Okay, so I'm looking at immune responses in children who are critically infected by HIV in Zimbabwe, specifically in Harare. So before I get into my project, I'll just kind of describe what Zimbabwe is and stuff. It's in southern Africa. It's the one in orange here. It's a small country. It's slightly smaller than the state of California, I think, in terms of area. There's 12 million people. I'm working in the biggest city there at the University of Zimbabwe. There's only one medical school, and it's at the University of Zimbabwe. It's in Harare, and that's where I'm based. I'm actually from Zimbabwe. I'm from Kwekwe, so it's kind of cool because I'm 3 hours away from home. And my parents still live there, so it's just amazing. All over the weekend. So with that, I guess I'll get started. So I'll start with my mentors, because I have a few of them at the village. They're very good scientists. So I have Dr. Gillian Kupakuwana, who is here. She is my UCSF mentor. She's my doorstep mentor. And she's actually really key in this, even though she's not the PI of the project I'm working in. And I'll kind of explain. I'm working with Dr. I'll just call her Dr. Terrio she's actually from Mass Gen. And I'm basically working under a Cape, she has a Cape grant, but she's a former people who swap at Harvard. And then I also have Dr. Palumsa, who is my designated mentor at Columbia, because this is technically a solvent project, which is required to graduate. So it's actually kind of cool because they all play different roles. So while she is the main, she's the PI of the project I'm working on, Sue Ellen has been very key for me because she actually is my contact for the UCSF lab in Zimbabwe. It is, I would say, the most well-equipped lab in Zimbabwe, period, in terms of basic science instrumentation and stuff like that. And this is a very heavily basic science project. So she kind of paved way for me to have access into this lab because it's the only lab of its kind, so it's very difficult to get into and to get permission to do work in there. So she basically kind of is the person who made it happen because she gives me access to this lab. And Dr. Larusa is my mentor, who keeps up on what I'm doing, if I'm writing papers, deadlines, IRBs, all this kind of stuff. So with that, I'll give you a very short background, not too much background on HIV itself, but just kind of just state with pediatrics, I guess. So about 92%, which is 2.3 of the 2.5 million, I think it's now at 3.1 million, I just checked, of the HIV-infected children live in sub-Saharan Africa. And the mortality in the absence of antiretroviral therapy is very high. And within a 5-year period, the survival has been estimated at 39%, and less than 10% of those children who are not on therapy actually mature into adolescence. So, but with the advent of antiretroviral therapy, the survival has dramatically improved, and this is awesome. But there is a big picture challenge, at least in resource-limited settings. Specifically, these children need lifelong treatment, and they have to have a very strong adherence. So there's a lot of work that's done on adherence to medication. And the complicated part for children is that they're not the ones who determine kind of the course of their health, because they're young and depend on the mother to be well informed, to be on top of giving the child the medication, not missing any medications. And a lot of these children, at least in sub-Saharan Africa, are also orphans because the parents may have died from HIV infection. So there's a lot of moving around with relatives. So that some of them will end up as lost follow-up because they were going to this clinic for therapy, but then they were moved with, to go live with some grandmother in the village, and so for months they don't have medication. It just goes on for a while. So we were looking at, I'm working at the Paranyako Hospital, which is the main tertiary institution in Zimbabwe. And that is a teaching hospital for the University of Zimbabwe. The main teaching hospital, there are a few of them, but it's a main teaching hospital for the University of Zimbabwe Medical School. And there's a clinic there called the Paranyako Family Care Center, which is an optimistic infections clinic. So that there's a few of these now in Zimbabwe. And this is the biggest cohort, the biggest pediatric cohort in Zimbabwe that come to this clinic. So it's actually for, specifically for HIV infection and all ages, from newborns all the way through. And I'll discuss a little bit about this unpublished data, but our data that we've been looking at, we've been working on a paper, I'll discuss that later, has showed actually about 44% treatment failure rate, and a lot of it has to do with poor adherence, and especially in adolescents. There's also not just the issue of what I was discussing a while ago, but an issue of the issues that come up with adolescence itself. And so while we're thinking about this and the advent of ARVs, the big picture is that there will be a need for a therapeutic vaccine that will induce an immune profile that mimics that observed in elite controllers of the virus. And so there's a small section of people who have HIV infection and are able to just be really good virologic controllers, and so they're not actually on any medication, but they're able to keep the virus under control for a very long time without needing medication. And so studying these people is really important in terms of trying to figure out if we can create a therapeutic vaccine. And efforts are actually underway for this, but this study specifically would be important because a lot of the efforts are looking at the adult population, and children's studies are kind of still being looked at, and this is one of them. So the specific aims of what I'm doing, this is a big study, and there are a few scientists. There are two main people in the lab who are working on this study, and I work on two of the specific aims, and a different colleague works on two of them. And what I'm working on is to investigate the differences in disease progression between these long-term non-progressors, or the elite controllers of HIV, and progressors who are the majority of people with HIV infection. And their immune profiles are specifically what I'm looking at. And to assess the functional deficits of art-mediated reconstitution. So after people have been immunocompromised and get on these on ARVs, what else is not being covered by ARVs? So that if a therapeutic vaccine is actually developed, it actually takes into account some of the challenges we have with the current ARVs. So these two elements will help guide therapeutic vaccine development for the pediatric population. So since we are taking this class, I thought I should have a table that looks like this. But the study is a prospective cohort study, and the outcomes I'm looking at are mostly immune responses is what I'm looking at. So I'm looking at a lot of cytokines and such things. I'll cover them a little bit later. And we also define the groups of working. So I'm working with children in the city of Harare because they're the ones who use this clinic. It is, and they're the ones who generally come to this clinic for their medications. Their parents go to this clinic, so they're easier for us to get hold of. And so we have different groups, and the study is actually going to go on for 2 years, but I'm there for the first year of the study. So that's it for this one. So to just kind of give an example of what I mean when I say I'm looking at immune responses, I won't go into the whole immunology map, but these are two of the cytokines I'm looking at. That's IL-2 and IL-7. So essentially what I'm working on is mostly CD4 responses. And what I'm looking at is not only the CD4 count itself, like the quantity of CD4 cells, which is generally what's used. I think CD4 count in viral load is what's used, but actually the functionality of these cells even after reconstitution and between progressors and long-term non-progressors. And what I mean by that is what these cells are producing in terms of how this affects their immune status, and also how they're responding to things like cytokines in terms of how they'll respond to stress, to infections, to new antigens. And so IL-2 and IL-7 are kind of an example of that. So these are the slew of experiments that I'm doing. There's a lot of them, and I won't cover them in great detail because of time, but I can talk about them later if somebody's interested. But basically I do these experiments at different time points, and to kind of cover an overview of how this is working is I generally, I've been in the clinic, with our research nurses so that I get used to understanding the population that I'm trying to study, and at the same time also with the efforts of recruiting the children who would be in our cohort. But basically, blood samples are what will be used for this study, and after we collect the bloods, after they're collected by the nurses, and then we take over on the lab side of things. So initially, the first thing we do is separate out the PBMCs, which are the cells, and then we separate the CD4s and CD8s, and then from there we actually start doing all the experiments to look at how well they're functioning, quantitating, and then also even quantitating how much of the viral load in terms of how much virus is in the participants. Some of the experiments are also going to be done in Boston just because we do not have the capacity to do them, but that's only 2 of the experiments, which is actually quite amazing that we're doing like 12 different experiments all in Zimbabwe, because Zimbabwe really has very limited capacity in terms of what you can do experimentally there. So it's really exciting even for the Research Council of Zimbabwe, because this is the first investigator-initiated study to be done in Zimbabwe where all the work, the bulk, at least 90% of all the experiments are being done in Zimbabwe, and they like to see that because a lot of work, I think people just come and collect samples and leave and go somewhere else and they publish a paper there. So this is exciting for them. So the second part, which is my aim 2, which is to assess the deficits that art, after reconstitution with art. And so it's actually a really important question, at least for the pediatric population, because a lot of these studies are done on adults. That's the way that the reconstitution happens for children and adults is very different because the children's thymus is still very active. And so in children, it is largely driven by the increase in naive T cells from the thymus, while in adults, it's actually dependent on peripheral expansion of T cells. So it's just peripheral expansion of T cells that are already there. So these things are actually really important to also do the studies in children because the profile looks very different and what's going on is very different in children than it is going in adults. So you would think that the reconstitution predominantly of naive cells should put children at an advantage to adults because they still have the source of these cells kind of still going. But unfortunately, there's been some studies that have shown that the rapid decline of the drop of the viral load right after ART can actually limit the development of the responses. But with that said, we are hypothesizing that ART fails to adequately restore these cells, especially the quality of the cells. So the CD4 count may go up and the viral load will go down, but the quality of the cells that have actually not been produced is not quite the same. And that's what we're looking at when I talk about immune responses. And do they have the same phenotype, like all the surface markers, all the receptors, all the things that were there in healthy individuals? Are we still creating the same cells after you've reconstituted a heart? And so that's what I'm working on. So to just kind of give an example of that, I'm looking at IL-7 as one of the main cytokines I'm looking at. There's been some evidence that has shown that at least in adults, this has not been studied in children, and so it would be the first of us doing this. But it would we're basically looking at the effects of IL-7, and one of the things that happens in HIV infection is that IL-7 is this very high concentration of IL-7 during HIV infection, and then after ART has been introduced, the concentration of IL-7 goes down, but what also goes up is the receptor to IL-7 in these T cells. And so it's really important for the receptor to be there for the cytokine to even do anything. And so part of what we're proposing is that these receptors are not actually restored back to the normal levels. So even after ART reconstitution and CD4 count looking good, the cells are not responding as well as they should be responding. So we'll follow this cohort of children who are long-term non-progressors. So our study will involve long-term non-progressors who are the elite controllers of the virus, who are not on ART. And then we'll also follow slow progressors who are also not on ART. The reason why we have this unique cohort of children who are not on ART, because I mean in the US you can't do the study. Everybody is on ART. In Zimbabwe, I think just recently the WHO just implemented that all children being born who are HIV positive at this point should all get on ART regardless of CD4 count, percent, or anything. But in Zimbabwe, as of right now, the guidelines are that I think people, including children, I think, will get on ART when their CD4 count goes down low enough to 250. And so that's why we have this unique cohort that we can work with when we're still at naive. But we do have controls of children. So in terms of what I've been doing, it's a little bit of a weird presentation because I've actually been in Zimbabwe since March. So I have actually started doing some things, and some of them we've actually set up our own lab, which is really exciting because it's the first basic science lab in the school. So it's really exciting. And we've gotten a bunch of instruments shipped from here in Europe and whatever. And it's been really exciting to get it set up. And what's also really nice is we're able to do the viral loads and CD4 counts for our population ourselves, because those are just backed up for like months. You don't get them if you send them to a central lab, so it's really exciting. But I've also done recruitment of the long-term progressives. These are very difficult to recruit because these are people who are doing really well, so they don't need to come to the clinic, and they're also not on medication. So it's very difficult to find them. So, but it's been really quite great. So I go to the clinic every day, and then I get 2 a day, and I'm so excited. And basically, the reason why we're able to find them is because some of them, their siblings are affected or parents are infected, are also affected, and so they come into the clinic and end up registering their children for the same reason. So they just come in for, I think, cotrimazole, which is what everybody is on who's HIV positive in Zimbabwe. And so I've also identified slow progressors, and some of these who are the easier ones to find will basically recruit as we start collecting samples. So the other part I've been working on is kind of an EPI project, which is we're preparing a manuscript that basically assesses the pediatric and adolescent HIV treatment in Zimbabwe. So it's a treatment cascade paper. And for you who do not know what the treatment cascade is, we're just basically looking from the point of diagnosis to the point of what our gold standard would be, which is doing well and anti-viral while you're on your medications. And so we're looking at basically how is this working. Really, it should not even be a pyramid, it should just be a rectangle going up. No one should be getting lost, but we do know that we lose people, and some people cycle through the system where they'll get on medication and then get off medication when they're feeling better, and then something happens and then they come back into the system, so some of them cycle. So basically we're looking at this, and it's actually more complicated for children because it's not as simple as them discovering this and then going with it. It starts with, this is some of my data, and that's why I got that 44% in one of the slides earlier. This is some of my data that we just compiled from data that came from the Ministry of Health, and also some data from our own in-house processional study that we've done. But there are 3 different cascades we would have to do for the young population, which is the prevention of mother-to-child transmission cascade, because this program was just implemented in Zimbabwe like a decade ago, so we're also just evaluating how well it's working, and that's for pregnant women and receiving all their treatments to reduce the vertical transmission. And then there'll be the infant cascade and then pediatric cascade, which is actually, in a way, the pathway would be similar to the adults, but these two are quite different, so we have to break them up. And so I've been working on this with people from the Ministry of Health, and we're going to present this data to them when I return back to Zimbabwe, which this is looking, pretty decent in the sense that 83% of all the women who need to be receiving are receiving it. Even though when we first got the data, they just said there was 100% coverage, and so I was like, wow, so there's no escape. And then we actually did the analysis, and we find that 17% are getting lost somewhere. And then when it comes to after the child is born, it's really dismal. So we're hoping that, we present it and we're in cordial with the Ministry of Health, and we'll be able to publish this data. And hopefully it's an advocacy type of paper for, while this is working, more needs to be done once the child is born. And that's all I have. So if you guys have questions.
Community members as far as community health workers to help increase advocacy, or is there any, has anyone looked at that when it goes to the loss to follow-up or the lack of adherence?
That's a really interesting, I'm actually not sure, because when I started working on the treatment cascades, when I started asking some of these questions, but I do think so. I can see how I know some more.
Our University of California, San Francisco UC collaborative is known globally for the community advisory boards and the extent of the outreach. But I think these numbers are very telling that despite having this huge presence and doing world-class research on HIV prevention, treatment, adherence, all kinds of things, there's still this huge gap. And I think that if you don't know about the history of Zimbabwe and the political situation in Zimbabwe, the socioeconomics of Zimbabwe, it's amazing that the adherence rates are as high as they are, because things are really unsettled, and the people are very, very, very transient, especially the poor. So yes, there are community outreach workers, and they are almost always quite appropriate for the variety of communities that exist in this catchment area, but it's still inadequate for the problems they're facing.
I was wondering what the percentage of births are at these kind of healthcare facilities, because in a lot of areas in the world, there are really a lot of home births, 80%.
I covered that actually.
Oh, sorry, did I miss it?
I didn't talk about it.
Oh, okay.
But in the paper that we're writing, we evaluated everything that we could. So, right from who went for antenatal clinic visits, and who gave birth at home, and who got what, and who got what type of treatment. Because some of them just get single dose therapy, and they're supposed to just take it themselves at home if they give birth there. We actually don't know if they take it. So.
Nice presentation, Jillian. I was wondering if you looked at your cascade by year, and I got the idea from Sue on this comment about the politics. So I'm wondering, it'd be interesting to show, and it would be an advocacy part too. When the infrastructure is good, this is what happens. When it's not, this is what happens. Instead of presenting it necessarily as a snapshot.
Well, in our paper we have data from 2010, 11, and 12, and there have been not great years, all of them for Zimbabwe, but I think 2010 might have even been worse. So yeah, I think I actually had not thought of stratifying it by year, but I think we can, because we do have the data to do it, and we're still preparing the manuscripts.
So I wonder if you could tell us how the information that you're going to generate in the study will be used to design the therapeutic vaccine.
Oh, how? Okay, so my understanding of it, so I kind of also have other ideas about what it could be used for. So it's not necessarily only therapeutic vaccines, but I'm interested in, for the DCR class, I'm actually kind of spinning off, writing a whole, fictitious proposal for, in terms of immune responses to childhood vaccinations. Just understanding what's going on with long-term non-progressors, with any progressors, and what does and does not reconstitute will be really important in terms of knowing what to wish to set the standard when the vaccine is being developed, and also to use to basically mimic how well long-term non-progressors are doing and why they're doing so well in the vaccine for the people who don't have those I think that's, I mean, on kind of on the big scale, that's what I'm thinking is gonna be done, is to just kind of use what already people who have superior immune systems are doing with this virus and hopefully be able to implement that, reproduce that somehow in the vaccine.
Thanks very much, Jim.
Next, Michael again is going to be talking about his project. Michael also comes from New York, but from a different school. And he's going to be doing a project in Thailand.
Thanks, Michael.